Good morning. I'm happy to represent this case of chest pain in elderly patient. Our patient is 70 years old male patient came to the ER complaining of severe chest and dorsal pain of a 1 week duration. The patient experienced dull ache left-sided chest pain scored as 8 in severity not related to the exertion associated with dorsal spine chest pain, sweating and exertional dizziness. The patient denied any loss of weight, anorexia, exertional pain, fever, or loss of consciousness. The patient has a history of hypertension 10 years ago, diabetes 7 years ago, and ischemic heart disease with two stents 5 years ago, for which he received the following medication: insulin, captopril, aspirin, Ator, and some tonics. The patient lives with his daughter. He can do normally his daily activity independently. Regarding his family history, no significant issue was addressed. His examination was unremarkable except for chest and dorsal spine pain on palpation. On initial visit, an ECG, chest X-ray, routine investigation, including liver and renal and electrolyte (CBC), and serial troponin were done. Patient kept in observation for 12 hours while he received painkiller, cardiac monitoring, and also orthopedic consultation. The patient condition improved and he was discharged as musculoskeletal pain. GB follow-up was recommended. 2 days later, the patient experienced the same pain and the same severity of the pain, but the pain awoke the patient from the sleep, mainly left-sided chest pain and also associated with dorsal pain. The vital sign was blood pressure 170/100 on the left arm, 166/95 on the left arm. Temperature 37, pulse 70 beat per minute, and saturation was 99. Pain is 8/10 on pain scale. The patient is conscious, oriented to time, person, place. On examination, head neck examination, only some pallor, normal jugular venous pulsation, normal thyroid examination, and no lymph node. Chest is bilateral vesicular breath sound, no added sound. Heart examination is normal S1, S2, and no added sound. The abdomen is soft, lax, no organomegaly. Lower limb is mild lower limb edema. Neurological normal power tone reflexes and sensation, and normal gait. Back examination is tenderness all over the spine and the chest wall. Also, this pain increases with movement of the left shoulder. ECG was done. ECG was normal sinus rhythm with non-specific STT changes. Chest X-ray was done. And on interpretation of the chest X-ray, there is an osteolytic lesion in the left scapula. No other abnormality was detected regarding chest X-ray. Lumbosacral, spinal X-ray, lumbosacral and pelvic X-ray, and also dorsal spine X-ray was done. It shows osteolytic lesion in the left hemipelvis with non-specific changes in the lumbosacral X-ray and dorsal X-ray. Investigation with normal apart from mild elevated liver function and elevated serum calcium. Provisional diagnosis that is metastatic back pain. So we search for other meds. CT chest abdomen was done, PET CT was done, and the conclusion is multiple osteolytic lesion found on spine, mainly in the dorsal spine and lumbosacral. There is unfortunately compression fracture in the D3 as shown in the CT, and osteolytic lesion also in the pelvis, osteolytic lesion in the left hemipelvis. The patient is admitted and prepared for bone marrow transplantation, bone marrow examination. Sorry. Bone marrow examination showed plasmacytosis, multiple plasma cells, more than 15%, also associated with this osteolytic lesion with hyperproteinemia, is suggestive of multiple myeloma. So the home message is any elderly patient come with chest pain, back pain, especially thoracic pain, with high risk factors or what's called the red flag signs of back pain, the elderly, the risk factor for coronary artery disease, nocturnal pain associated with loss of weight or anorexia, all these called red flag sign of back pain, of back pain. So you must respect it. Good history, good examination, and investigation. Thank you.